Welcome to the Deep Dive, where we really try to unravel complex topics and bring you truly insightful knowledge. Today, we're delving into a medical challenge that literally reshapes a baby's future: craniosynostosis. Our mission is to navigate the intricacies of premature skull-bone fusion, understanding its profound impact on development, how medical teams precisely diagnose it, and, well, the incredible advancements that are now rewriting these children's stories. You've shared some compelling sources on non-syndromic craniosynostosis, and we're ready to uncover the crucial insights.
Indeed. And what's so striking about this condition is how something seemingly straightforward, the early fusion of skull sutures, can trigger such a complex cascade of developmental effects if it's not caught and addressed.
Yeah.
It's a powerful illustration of the delicate balance in early human development.
Absolutely. And it's more prevalent than you might think. I found it striking that our sources highlight this condition affects roughly 1 in 1,000 live births in the United States. That number alone, to me, really underscores the widespread nature of this challenge and why understanding it is so important. Okay, let's really unpack this. At its core, craniosynostosis is when one or more of an infant's skull sutures fuse prematurely. Think of sutures as the soft, flexible seams between the separate bony plates of a baby skull. They're designed to stay open for a while.
Right, they need that flexibility.
Exactly. Our sources differentiate between non-syndromic forms, which is what we're focusing on today, meaning it's an isolated condition without other associated problems, and syndromic forms, where it's part of a broader genetic condition.
This immediately raises the question, why does this happen? The pathogenesis, essentially the origin and development of the disease, it's complex.
Right.
And likely has multiple contributing factors. Our sources suggest various causes, from primary abnormalities in the sutures themselves to extreme forces affecting the dura, that's the tough protective membrane surrounding the brain, or even inadequate forces from the growing brain itself. It's not like a single switch that gets flipped, but more likely a combination of genetic and environmental influences creating this unique puzzle.
And why is this early fusion such a profound concern for a developing infant? It all comes down to brain growth, which is truly phenomenal in early life. Imagine the brain as a balloon rapidly inflating within a flexible but ultimately confined space.
A very dynamic process.
Totally. The cranial vault, or the top of the skull, achieves about 80% of its adult size at birth, reaching its definitive size by about 2.5 to 3 years of age. Critically, the brain's volume almost triples in the first year alone.
Triples.
And it's 4 times its birth size by age 2. Those open, flexible sutures are absolutely essential for this rapid expansion to happen without restriction.
You need that room.
When they fuse too early, that crucial growth can be hindered, potentially with long-lasting effects.
Precisely. And if we connect this to the bigger picture, the functional problems associated with the craniosynostosis are significant. They often develop gradually, which can make them difficult to detect in their early stages.
Right, subtle at first.
And crucially, they can become irreversible if not addressed promptly. These are the fundamental why behind the critical need for early intervention.
Our sources highlight 4 major functional problems that can arise, and they really emphasize that this isn't just about appearance. First, there's intracranial hypertension, which is simply too much pressure inside the skull. We're talking about pressure greater than 15 millimeters of mercury, a benchmark medical professionals use.
Yeah, that's the threshold.
To give you some perspective, even with just one fused suture, roughly 1 in 8 children can develop this dangerous pressure.
That's quite high.
And that risk actually skyrockets to over 40% when multiple sutures are involved.
Wow.
What's truly concerning is how stealthy it can be. Early symptoms are often subtle things like headaches in older children, increased irritability in infants, or difficulty sleeping.
Very nonspecific signs sometimes.
Exactly. Later, you might see radiographic signs on scans, like cortical thinning, where the skull bones become thinner, or a hammered metal appearance, which looks exactly as it sounds, like someone hammered the inside of the skull.
But those are late signs.
But these are considered relatively late developments, meaning the pressure has been building for a while. Untreated, this can severely affect brain function and necessitate early operative intervention. Secondly, we have visual impairment. Untreated intracranial hypertension, especially in its acute phase, can lead to papilledema, that's swelling of the optic nerve.
Right, the nerve connecting the eye to the brain.
Which carries visual information from the eye to the brain. chronically, this can progress to optic atrophy, potentially causing partial to complete blindness.
A very serious consequence.
And beyond pressure, some forms of craniosynostosis can also involve orbital hypertelorism, which is an abnormal widening between the eyes. And this can directly affect visual acuity and binocular vision, meaning how both eyes work together.
So multiple ways vision can be affected.
Yeah. Our third crucial point is the limitation of brain growth. As we touched on, the brain's volume triples in that first year. When sutures fuse prematurely, it literally creates a restrictive, rigid container that prevents the brain from expanding as it should.
It's like putting a lid on it too soon.
Exactly. While surgical intervention aims to provide release and reshape the skull to restore more normal intracranial volume, our sources note that a diminished brain volume is often the end result, even after surgery.
So even with intervention, there can be lasting impact on volume.
Seems so. And finally, neuropsychiatric disorders. These are believed to be secondary to the cerebral compression caused by that restricted space. The disorders can range from mild behavioral disturbances to more significant developmental delays.
A wide spectrum.
The good news here, though, is that children with these associated neuropsychiatric disorders often show significant improvement after cranial vault reconstruction.
That's encouraging.
Which is a powerful argument for early and effective treatment.
Precisely. And that emphasis on early and effective intervention is where advanced diagnostic tools truly shine. It's fascinating how imaging technology, specifically CT scans, has become so vital not just for confirming a diagnosis, but actually for quantifying intracranial volume.
Measuring the inside space.
Exactly. This capability helps identify children who are at a greater risk for developing these serious functional problems, like intracranial hypertension, and therefore might benefit the most from early surgical intervention, allowing for more targeted and timely treatment before irreversible damage occurs.
So, given all these potential impacts, how is craniosynostosis actually detected? We learned that one should suspect it in any infant with an abnormal head shape.
That's the first clue, usually.
The definitive diagnosis relies on both careful clinical evaluation and sophisticated radiographic assessments.
Clinically, this involves a very hands-on approach. Careful palpation of the skull, meaning gently feeling for any abnormal movement of the bones, feeling for ridging along the sutures where they shouldn't be fused, and assessing the presence and status of the anterior and posterior fontanelles.
The soft spots.
Right. Just as a quick reminder, the anterior fontanelle, the soft spot on top, typically closes between 9 to 12 months, and the posterior fontanelle at the back usually closes earlier, between 3 to 6 months.
Okay. And radiographically.
Well, while conventional skull films like plain X-rays are inexpensive and widely available,
Sure.
showing patent sutures as a clear line and suggesting fusion if that line is absent, it's the advent of CT scans with three-dimensional reconstruction that has truly revolutionized both diagnosis and surgical planning.
The 3D views must make a huge difference.
Oh, absolutely. These images provide unmatched detail of the bony facial structures, allowing surgeons to precisely understand the anatomy before they even begin. What's more, CT scanning has even been used to document surgical changes in vivo and to follow developments longitudinally.
So you can track progress over time.
Exactly, showing just how indispensable it's become in tracking a child's progress.
Okay, so let's talk classification.
Right. The way craniosynostosis is classified is quite logical, based directly on the distinct skull shapes that result from the premature fusion of specific sutures. Each fused suture creates a characteristic and often quite dramatic deformity. It's like each suture has its own unique blueprint for skull shape.
Let's walk through some of the major types, because this is where you can really start to visualize the impact and truly understand how these tiny skull bones guide growth. First up, unilateral coronal synostosis. This leads to what's called anterior plagiocephaly.
Plagiocephaly, meaning an oblique or slanted head shape.
Right. You typically see a noticeable flatness on one side of the forehead and the bone above the eye, making the head asymmetrical, especially when viewed from above. It accounts for about 20% of nonsyndromic cases. And it's really important to distinguish this from infant molding or positional plagiocephaly.
Very important distinction.
Which is much more common and happens when a baby lies in one position too much, but isn't due to suture fusion.
Right. Different cause, different treatment.
Then there's bilateral coronal synostosis. This results in brachycephaly.
Brachy meaning short, so a short head shape.
Characterized by a recession of both bones above the eyes, meaning the eyebrows sit further back than they should. The forehead appears lower, the skull ends up shorter in length. But because the brain still needs room, it often compensates by growing high and wide in other areas.
Compensatory growth is key here.
This accounts for about 20% of isolated cases and is also very common in syndromic forms like Eppert's and Crouzon's syndromes.
Correct.
Next, we have metopic synostosis. This typically causes trigonocephaly,
Trigono like a triangle.
literally giving the skull a triangular shape when viewed from above, often with a prominent midline keel along the forehead that you can often feel. It represents about 10% of non-syndromic cases.
That keel is quite characteristic.
The most common form is sagittal synostosis, making up a significant 50% of all single suture cases.
Half of them. Yeah.
It leads to scaphocephaly.
Scapho, like a boat. An elongated shape.
Exactly, where the skull becomes long and narrow because it can only grow forwards and backwards, not sideways. Interestingly, the material highlighted that this specific type is rarely associated with increased intracranial pressure.
Which is a key clinical point for sagittal synostosis.
Yeah, definitely. Finally, we have unilateral lambdoid synostosis. This results in posterior plagiocephaly,
Flatness at the back on one side.
causing flatness in the back of the head on one side, with the ear on the affected side appearing more posterior and inferior. It's relatively rare, less than 3% of isolated cases. And again, careful distinction from positional plagiocephaly is key, especially since positional plagiocephaly is often treated successfully with molding helmet therapy, not surgery.
Absolutely critical not to misdiagnose positional plagiocephaly as lambdoid synostosis.
So these distinct shapes really paint a picture.
They truly illustrate that each fused suture creates its own unique architectural challenge for the developing brain. This highlights why diagnosis isn't just about a fused suture, but which suture, because that dictates the specific risks and guides tailored treatment. This precision isn't just academic, it directly informs a child's entire treatment pathway.
Which brings us to management. Given the complexity and potential impact, the management of craniosynostosis places a huge emphasis on a highly coordinated, multidisciplinary team approach.
Absolutely essential.
We learned this model was actually developed in response to the failures that commonly occurred when various aspects of care weren't coordinated.
Right, when specialists worked in silos.
And the relationships among coexisting problems weren't fully understood or addressed. It truly takes a village to ensure comprehensive care.
Exactly. The team works together on diagnosis, formulating and executing treatment plans, and crucially, long-term follow-up. It's not just the surgeon. You have a whole network of specialists involved.
Our sources describe an impressive list of professionals that might be on such a team. You're looking at surgical specialists, of course, but also diagnostic experts and a whole network of developmental and psychosocial support professionals, from pediatric anesthesiologists and ophthalmologists for vision, to audiologists for hearing, to speech pathologists, psychologists, geneticists, and social workers all working together
It's comprehensive.
to support not just the physical correction, but the child's entire long-term development.
The current surgical approach has clearly defined dual goals. The first, and most critical, is to allow the brain to grow and expand without restriction.
Release the pressure, give it room.
Precisely. The second goal is to establish a more normal and aesthetically pleasing contour to the forehead, the bones above the eyes, and the overall skull. These two goals are really intertwined.
Makes sense. When it comes to timing, our sources indicate a preference for early surgical repair, generally performed between 4 and 8 months of age.
That's the typical window, yes.
There are several good reasons for this. It allows for rapid frontal lobe growth, which supports forehead and suborbital ridge advancement. The cranium is also highly malleable at this age,
Much easier to work with.
making it easier to contour, and residual bony defects tend to heal more rapidly during this period of growth. For more severe forms, additional revision surgeries of the cranial vault and orbit may be necessary later in infancy or early childhood.
Sometimes multiple stages are needed.
And a significant advancement in surgical technique is the use of resorbable plates and screws,
This was a game changer.
typically made of polylactic and polyglycolic acid. These materials maintain sufficient stability for initial healing and bone fixation. But here's the genius part. They are completely resorbed by the body through hydrolysis within 9 to 14 months.
Yes, it does dissolve over time.
This minimizes any future growth restrictions that permanent hardware might cause, and also avoids the potential for transcranial migration where hardware could potentially move through the skull.
Right, avoids long-term complications from hardware. It's a far cry from older, more invasive methods that use permanent fixation, like wires.
It's truly remarkable to consider that shift. Imagine the difference for a developing child, knowing that the material supporting their early healing will simply dissolve away, leaving their natural growth unimpeded.
It really speaks to the ingenuity pushing this field forward.
And these surgical techniques are highly tailored to the specific type of synostosis. For example, in sagittal synostosis, while a simple strip craniectomy, essentially just removing the fused suture as a strip, was once common.
An older technique.
The research states that a formal total cranial vault reshaping is now often preferred to achieve better improvements in cranial vault shape.
More comprehensive reconstruction.
There's even a trend towards earlier surgery, under 4 months, involving the removal of the steno suture, along with extensive barrel staving, which is essentially making small strategic cuts in the bone to allow it to expand and reshape like the staves of a barrel.
Got opening things up.
And post-operative helmet molding. This promises potentially better outcomes with less blood loss and shorter operative times.
It's clear how much the field has evolved, constantly seeking less invasive, more effective solutions.
This deep dive into non-syndromic craniosynostosis really underscores the incredible advances in pediatric craniofacial surgery. From understanding the subtle, often insidious signs of intracranial hypertension to the precision of 3D CT scans and the innovative use of resorbable materials.
Quite a journey.
It's a testament to how specialized medical teams are transforming lives and rewriting the developmental stories of these children.
It really reminds us that early detection and a comprehensive, coordinated, multidisciplinary approach can truly make all the difference in mitigating potential developmental challenges. The revolutionary techniques introduced by figures like Paul Tessier back in 1967 truly paved the way for modern management.
A real pioneer.
And have profoundly improved the care for these complex pediatric craniofacial deformities.
So, what does this all mean for you, listening? It's a powerful reminder of the intricate and rapid development happening in those crucial early months of life, and the amazing capacity of medical science to intervene and correct serious conditions.
It really is remarkable.
It also highlights the importance of recognizing abnormal head shapes in infants and seeking expert advice promptly, because early intervention can change a child's entire developmental trajectory.
Definitely don't wait if you have concerns.
Yeah.
Perhaps a provocative thought to leave you with. As surgical techniques continue to refine and advance and our understanding of brain development deepens, what further role might non-invasive monitoring and even preemptive interventions play in the future?
Interesting.
Could we move beyond simply treating the structural issues to truly optimizing long-term neurological development, even before major surgery is considered?
A truly profound question to ponder as medical science continues its relentless quest for better outcomes. Thank you for joining us on this deep dive. We hope you feel a little more well-informed and perhaps a lot more curious about the wonders and challenges of human development. Until next time.